Now we're going to continue our talk on strabismus. Strabismus is deviation of one eye away from the fixation point. So one eye is looking to the object, the other eye is not looking to the object. Or it's ocular misalignment. Ocular means eye, mis means abnormal, alignment means straight. So the eyes are not aligned together and both eyes are not straight. One eye is straight and the other is misaligned. Classification of strabismus. Strabismus could be false or pseudo or apparent. The patient looks as if he has strabismus, but he does not. He's absolutely normal. Or it could be true, there is strabismus. The true could be hidden, which is latent strabismus or heterophoria, and only appears by covering one eye or by certain tests. Or it could be manifest. We see the patient squinting once we meet him. So it's manifest or heterotropia. And manifest strabismus could be comitant, where there is no limitation of movement in any direction of gaze, or could be incomitant, where there is limitation of movement in certain directions of gaze, in one or more direction of gaze. And the incomitant could be due to paralysis of extraocular muscles, so it's paralytic, or due to restriction and fibrosis of the extraocular muscles, so it's restrictive. We're going to talk on each type in details. Another classification of strabismus is based on the eye position, convergent or esodeviation, where the eye moves towards the nose, divergent or exodeviation, where the eye moves outwards towards the ear. So exodeviation, like external, the eye moves externally. Or vertical deviation, which is hyperdeviation or hypertropia, where the eye moves up. In order to diagnose which type of strabismus the patient has, we have to go through all these steps: history taking, visual acuity measurement, sensory testing, motility testing, cover test, angle of deviation, cycloplegic refraction, and fundus examination. History taking. We ask for age of the patient, age at onset of strabismus. If strabismus starts during the first 6 months of life, it's considered congenital. If it starts later on, it is acquired. We ask if the strabismus is unilateral, which means one eye is squinting all the time, or alternating. The patient sometimes squints with the right eye, sometimes squints with the left eye. If it's constant, present all the time, or intermittent, sometimes the patient has strabismus and sometimes his eyes are straight. If the patient wore glasses before, performed occlusion therapy for amblyopia, where we cover the normal eye to improve vision in the abnormal or amblyopic eye, or if the patient had previous extraocular muscle surgery. We ask for systemic diseases, and this is very important, and for family history of strabismus. For systemic diseases, we ask for diabetes and hypertension, or any other disease the patient may have. An interesting case that I've come across was a lady who came complaining of diplopia. I asked her, do you have any other disease? She said she had amenorrhea and galactorrhea. This drew my attention to some pituitary lesions, so I performed a field of vision or perimetry, and she had bitemporal hemianopia. And I ordered MRI, and it showed this huge pituitary macroadenoma, and it was compressing the chiasma, producing the bitemporal field effect. And if this patient was left, she would have turned blind or would have died. So if we need to ask carefully for any systemic diseases, because this strabismus could be just pointing out to a systemic disease, not just strabismus and that's it. So inquiry for any systemic disease is very important, could be vision saving and life saving. Next step in clinical evaluation is visual acuity measurement to diagnose amblyopia. What's amblyopia? Amblyopia means diminution of vision in the eye without a detectable cause. For example, The patient has refractive error. We gave him proper glasses. He had cataract. We removed the cataract. We implanted intraocular lens. We removed the cause of poor vision, but still the patient has poor vision. So why does he still have poor vision? Because of amblyopia. The brain ignores or neglects the eye that gave him poor vision for a while during childhood. And this neglect of the eye will make the vision come poor and poor. So the brain does not receive any image from this eye. Continuous suppression of the eye will produce amblyopia. So even if we give the patient the proper glasses, if we do cataract surgery, if he needs cataract surgery or whatever, we remove the cause, still the patient does not see well. So it's diminution of vision in an eye without a detectable cause. How do we diagnose amblyopia? We measure the vision after correction of refractive error. We give the patient the glasses needed to improve vision, and we measure the vision. In amblyopia, the vision of the squinting eye does not improve with corrective glasses. The vision of the amblyopic eye still does not improve. So this means the patient has amblyopia. And we usually consider amblyopia to be significant if there is a difference of 2 lines or more between both eyes, or if the vision is 6/12 or less. Types of amblyopia: strabismic, anisometropic, or sensory. If the patient has strabismus in one eye all the time and not alternating between both eyes, the squinting eye will give a poor image to the brain. So the brain will suppress this eye or neglect this eye. By time, the vision in this eye becomes poorer and poorer, and the patient develops amblyopia. So strabismus leads to amblyopia, and also amblyopia leads to strabismus. If an eye has poor vision and becomes amblyopia, this eye will squint, will get strabismus, because the brain neglects this eye and does not maintain proper muscle balance in this eye. So the eye will start to squint. The second type is anisometropic amblyopia, which is due to difference in the refractive error between both eyes. For example, one eye is +1, the other eye is +5. The image from the +5 eye, if the patient does not wear glasses, will be very blurred. So the brain will neglect this eye, will suppress this eye, and by time it will become amblyopic. Or sensory, which means there is a corneal opacity, or there is a cataract or macular scar in one eye. So this eye gives poor image to the brain. The brain neglects the eye or suppresses it. By time it develops amblyopia. So we tested for visual acuity to determine if the patient has amblyopia or not. In grown-up children and adults, for example, children who are 4 or 5 years old or older, we can test vision by the charts, the regular charts used for adults. But for smaller ones, we examine fix and follow. We ask that we cover one eye and we hold a toy for the child, and we see if the child fixes on the toy or not. And we move it up, down, right, and left, and we see if the child follows the toy or not. If the patient has fix and follow equally with both eyes, this means there's probably no significant amblyopia. Or if the patient has alternating strabismus, he squints with the right eye and then he squints with the left eye and not squinting with one eye all the time, this is a sign of no amblyopia. The next step in the examination is the sensory testing, where we determine by certain tests if the patient has binocular single vision or fusion, or the patient does not. And if the patient does not, does the patient have diplopia, double vision, or suppression, where the brain suppresses one eye? So we use certain tests to determine if the patient has binocular single vision or not. The fourth step in the examination is the motility testing, where we test movement of the eye in different directions of gaze. We test for ocular motility in the 9 cardinal directions of gaze as mentioned earlier. As seen in this picture, we test for motility in the primary position, right, left, up and to the right, down and to the right, up and to the left, down and to the left, to test for limitation or overaction of any extraocular muscle. And as I mentioned before, we test for direct up and direct down gaze to test for pattern. We evaluate ocular motility by ductions, versions with an S, and versions with a G. Ductions means monocular eye movement. We cover one eye and we test the motility in the other eye. So we cover one eye and we test motility on gaze to the right, to the left, up and to the right. Test for the superior rectus, down and to the right for the inferior rectus, up and to the left for the inferior oblique, and down and to the left for the superior oblique, as seen in this picture. So we test in the 6th cardinal position of gaze. The medial rectus adducts the eye, the lateral rectus abducts the eye, superior rectus elevates the abducted eye, inferior rectus depresses the abducted eye, and as I mentioned earlier, the abduction here is done by the lateral rectus, and the superior rectus only elevates and the inferior rectus only depresses the globe. Inferior oblique elevates the adducted eye, and the superior oblique depresses the adducted eye, and as I mentioned earlier, the adduction is done by the medial rectus, and the inferior oblique only elevates the globe, and the superior oblique only depresses the globe. We test for ductions first for the right eye with the left eye covered, and then for the left eye with the right eye covered. If the eye reaches till the end with no scleral show at all, this is called zero limitation or normal duction. If we see a tiny bit of sclera, it's called -1 limitation or slight limitation. If we see more, it's -2. More, it's moderate limitation, where the eye just moves past the midline. And if the eye cannot cross the midline, it's called -4 or severe limitation. The next is the binocular conjugate eye movements, or the versions with an S, where both eyes are tested, both eyes are opened, and they move in the same direction. So we test in the 9 versions in the 9 cardinal positions of gaze. On gaze to the right, gaze to the left, up and to the right, down and to the right, up and to the left, down and to the left, and direct up and direct down, as in this picture. So this girl has no limitation of movement in any direction of gaze. She has normal versions. And this boy who has right esotropia, he has squint, but he has normal versions. There's no limitation of movement in any direction of gaze. Binocular disconjugate eye movements, or versions with a G, where the eyes move in opposite directions. And versions could be conversions or diversions. Conversions, on looking at a near object, both eyes adduct or move inwards to see the object. This is called conversions. When you look to a far object, both eyes diverge or move out, and this is called diversions. So evaluation of ocular motility is by ductions, where one eye is covered, by versions, where both eyes are uncovered, and by versions with a G to test for conversions and diversions. So we talked about history taking, visual acuity measurement, sensory testing, motility testing, and the next step, which is a very important step in the examination, is the cover test. The cover test diagnoses the type of strabismus, whether it's apparent, latent, or manifest, whether it's an esodiviation, an exodiviation, or a hyperdeviation, and whether it's unilateral or alternating. For example, this diagram shows a patient with no strabismus, or could be having just an apparent or a false strabismus. The light reflex is in the center of the pupil of both eyes, so both eyes are fixating on the object. He has straight eyes. We cover one eye. For example, we're covering the right eye here, and we look at the left eye. If the left eye does not move to pick up fixation, it means it was straight, so it did not need to move. So we are now sure there is no manifest strabismus. And then, is there latent strabismus or hidden strabismus or not. If there is latent or hidden strabismus, the right eye that's covered will deviate, because covering one eye reveals any hidden or latent strabismus. If the eye under the cover deviates, this means there is latent strabismus. If the eye under the cover does not deviate, this means the patient does not even have latent strabismus. How do you know that? When we remove the cover, if the covered eye starts to move back to the center to pick up fixation, it means it was deviated under the cover. So there's latent strabismus. If when we remove the cover, the covered eye, when we uncover it, does not move to the center to pick up fixation, it means it was straight under the cover. So there is no latent strabismus. So in the first picture, both eyes are fixating. Cover one eye. There's no movement in the left eye, and the eye under the cover, we do not see it. And then we remove the cover. If the covered eye does not move to pick up fixation, this means there is no strabismus. So a patient with no strabismus or apparent strabismus does not move any eye to pick up fixation with the cover test. And we repeat the cover once for the right eye and once for the left eye. If the patient has latent strabismus, which means hidden strabismus, why is it hidden? Because the brain exerts control on the muscles to keep its balance. Why? Because the brain wants the eyes to be straight and the eyes to be fixing with the fovea in order to fuse the image and have binocular single vision. So how can we show the latent strabismus? If we cover one eye, there's no more stimulus for the brain to maintain the eye straight, because there's no more two images that need to be fused. It's only one image by the uncovered eye. So in this case, the brain does not exert its control on the muscle balance anymore, and the latent strabismus will appear. So to show up the latent strabismus, we cover one eye. And so as seen in the upper picture, both eyes are fixating. There's no strabismus in any eye. We cover one eye, for example, the right eye. The right eye under the cover deviates. And when we remove the cover, we see the deviated eye moving back to the center to pick up fixation. This movement means it was deviated under the cover. So this patient has latent strabismus that only occurs when one eye is covered, but does not occur when both eyes are fixating, because the brain prevents its appearance. The last type is the manifest strabismus. We see the strabismus once we meet the patient. For example, here the right eye is fixating, the left eye is deviated. So there is manifest strabismus. We want to make sure we cover the fixating right eye. The left deviated eye will move to the center to pick up fixation, because now the patient does not have another eye to look with. So he has to move this eye to reach the center to pick up fixation. The presence of this refixating movement means the eye was deviated. So it means there is manifest strabismus. And for the left eye to move outwards to reach the center to pick up fixation, the right eye has to move in the same direction. So the right eye will go in adduction or will get a convergent strabismus under the cover. So the right eye is fixing in the upper picture, the left eye is deviated. We cover the right eye, the left eye moves to the center to pick up fixation. This means there is manifest strabismus in the left eye. And we perform the test for both eyes. So the cover test diagnoses the type of strabismus, whether it's apparent, latent, or manifest. Whether the next step, it will diagnose if the strabismus is an esodeviation, an exodeviation, or a hyperdeviation. For example, if the patient has esophoria or latent convergent strabismus, in the upper picture, both eyes are straight or fixating. We cover one eye, for example, the right eye. And then under the cover, the eye, because there is latent strabismus, there is esophoria, the eye moves inwards. We remove the cover. The eye moves from inwards to outwards to reach the center to pick up fixation. This direction of refixating movement means the eye was convergent under the cover. So there is esophoria. So in the upper picture, both eyes are fixating. Cover one eye, and then remove the cover. The eye moves outwards to reach the center to pick up fixation again. So there is esophoria or latent convergent strabismus. If there is exophoria or latent divergent strabismus, the same. In the upper picture, both eyes are fixating. We cover one eye, for example, the right eye. Under the cover, the right eye deviates outwards, but we do not see the eye under the cover. But when we remove the cover, the right eye moves inwards to reach the center to pick up fixation. So this direction of refixating movement tells us where was the eye under the cover. So the eye was exophoric under the cover. So this patient has exophoria. Tropia or manifest strabismus. Esotropia, for example, the right eye is fixating, the left eye is deviated inwards, or there is esotropia or manifest convergent strabismus. To make sure we cover the right eye, the left eye moves from nasal to temporal to reach the center to pick up fixation. This movement from nasal to temporal or from inwards to outwards means that the eye has esotropia or manifest convergent strabismus. And under the cover, the other eye has to be esotropic because it has to move in the same direction as the left eye. In exotropia, the eye is deviated outwards. If we cover the right eye, the fixating right eye, the left eye will move from outwards to inwards to reach the center to pick up fixation. This outwards to inwards movement means the eye was exotropic or divergent. So this patient has exotropia or manifest divergent strabismus. If the eye has hypertropia, the right eye is fixating, the left eye is deviated. We cover the right eye, the left eye moves from upwards to downwards to reach the center to pick up fixation. So this downwards movement means there is hypertropia. So by a cover test, we can determine if the deviation is an esodeviation, an exodeviation, or a hyperdeviation. The last value of the cover test is to determine if the strabismus is unilateral, where one eye always squints and the other eye is always straight, or alternating, where the patient sometimes squints with the right eye and sometimes squints with the left eye. As seen in this diagram, the right eye is deviated and the left eye is straight. We cover the straight left eye. The right eye will move to the center to pick up fixation. Then we remove the cover and we observe. If after removing the cover, the right eye can still maintain fixation or can still be straight for at least 5 seconds, this means the patient has alternating strabismus. He can fix with the right eye for some time and with the left eye for some time. If on removing the cover, the right eye immediately squints again and the left eye immediately becomes straight again, this means the patient cannot maintain fixation with the right eye. So the squint is only in the right eye, or this patient has right esotropia. So if the patient can maintain fixation with each eye for at least 5 seconds, this means he has alternating strabismus. If the patient cannot maintain fixation with the non-preferred eye for even 5 seconds, it means the patient has unilateral strabismus, and this is a sign of amblyopia. As seen in this girl in the upper picture, she has left exotropia. We cover the right eye. The left eye moves to the center to pick up fixation, and under the cover, we see that because this is a transparent cover, we see that the right eye is squinting. We remove the cover. She can still maintain fixation with the initially squinting left eye. So she squinted first with the left eye, and she's now squinting with the right eye. So she's alternating her exotropia between both eyes, and this is a sign of no amblyopia. This boy has left esotropia. We cover the right eye. This is a transparent occluder where we can see the eye of the patient, but the patient does not see anything. So under the cover, we can see the right eye is now esotropic because the left eye is fixating. When we remove the cover, immediately the left eye squints again. So he has left esotropia, which is a sign of left amblyopia. This girl has right esotropia. We cover the left eye, the right eye becomes straight. But once we remove the cover, the right eye immediately squints again. So she has right esotropia, which is a sign of right amblyopia. So the cover test diagnosed the type of strabismus, whether it's apparent, latent, or manifest, an esodeviation, an exodeviation, or a hyperdeviation, and whether it's unilateral or alternating. The next step in the examination is measurement of the angle of deviation. We measure the angle of deviation by the corneal light reflex test, or the Hirschberg test. And this is a very crude or rough method to measure an angle of deviation. We should not use this method to determine the amount of surgery to be performed, but we should use prisms, which is a more accurate method to determine the amount of surgery to be performed. How to perform the corneal light reflex test? Our eyes will be exactly in level with the patient's eyes. We should not be higher or lower than the patient, and we should not be on the right or the left side of the patient. We should sit exactly in front of the patient. And we shine light over torch in the middle between both eyes, exactly in the middle. If the light reflex falls on the center of the pupil of the right eye and the center of the pupil of the left eye, this means the patient has straight eyes or orthotropia, i.e. no manifest strabismus. But we don't know if he has latent strabismus or not. But he has no manifest strabismus or orthotropia. Ortho means straight. If the light reflex falls on the center of the pupil in one eye, but on the temporal part of the cornea in the other eye, this means the patient has esotropia or manifest convergent strabismus. As in this girl, the light reflex in the left eye is in the center of the pupil, in the right eye it's on the temporal limbus. If the light reflex falls on the center of the pupil in one eye, but on the nasal part of the cornea in the other eye, it means there is exotropia or divergent strabismus. As in this patient, the right eye, the reflex is in the center, the left eye, the reflex is on the nasal part of the cornea. So she has exotropia or manifest divergent strabismus. So the corneal light reflex test determines if the patient has no strabismus or orthotropic, or there is heterotropia, which could be an esotropia, an exotropia, or a hypertropia. How much of deviation the patient has, which is the angle of ocular deviation. For every 1 millimeter displacement of the light reflex from the center of the pupil, this equals to 7 degrees of ocular deviation. For example, if we consider the horizontal diameter of the cornea is 12 millimeter, if the light reflex is displaced from the center of the pupil to reach the limbus, so it's displaced by half of 12, i.e. 6 millimeters. 6 times 7 is 42 degrees. So at the limbus, it's around 40 degrees. If the normal pupil size is 3 millimeters in diameter, So if the light reflex is displaced from the center of the pupil to reach the edge of the pupil, is displaced by 1.5 times 7 degrees. So there is 10 degrees of strabismus. It's just a rough and a crude method. And if the light reflex falls midway between these 2 points, we determine how many millimeters is it displaced from the limbus or from the edge of the pupil, and we determine if it's 20 degrees, 25, 30, 35, and it's a very rough and crude method. For example, the boy in the upper right picture, he has around 10 degrees of strabismus. The girl in the upper left picture, she has around 15 or 20 degrees. The ones in the middle, the girl has around 25 or 30, the boy is around 35, the one on the right, around 35 degrees, and the inferior girl, where the light reflex is exactly at the limbus, she has around 40 degrees of strabismus. But the more accurate method is using prisms to measure an ocular deviation. These are the prisms used, and we use it to measure the ocular deviation to determine the amount of surgery to be performed. The next step in the examination is the cycloplegic refraction. To determine the refractive error of any patient, any young patient, and sometimes say it's up to 21 years of age, we have to use cycloplegic medications. Usually we use cyclopentolate eye drops. We instill 1 drop in each eye, and then another one after 5 minutes. So we instill 2 or 3 drops each 5 minutes apart, and we refract the patient 30 to 60 minutes later. For atropine eye ointment, we use ointment, not drops, because drops will produce atropine toxicity and the child will get a fever due to absorption from the nasal mucosa. So we use the ointment, not the drops, and we use it 3 times daily for 3 days at home, and the patient comes on the 4th day for refraction. We very rarely need atropine. We usually use cyclopentolate eye drops in the clinic, and we refract the patient 30 to 60 minutes later. So, for example, a patient can have a refractive error before cycloplegia of +1, and after cycloplegia, where cycloplegia paralyzes the ciliary muscle, the refractive error becomes, instead of +1, becomes +5 or +6. So +5 or +6 is the true refractive error of the patient, and we give glasses according to this refractive error. And sometimes before cycloplegia, we find a child of -7 or -8, false myopia. It's not true, it's false or pseudomyopia. And after cycloplegia, this -7 or 8 becomes -1 or 0 or even +1. And pseudomyopia is common these days due to the excessive use of digital devices. So cycloplegic refraction is of utmost importance to determine the true refractive error of the patient and the true glasses that the patient needs to wear. The last step in the examination is the fundus examination. Fundus examination is very important because the patient may not only have strabismus, he could have something much more serious. For example, a patient can have a retinoblastoma, a malignant tumor of the retina affecting the fovea, so the child does not see, he develops strabismus. His problem here is not the strabismus, it's the malignant tumor of the retina. So we have to check the fundus for any dangerous pathology or for an untreatable pathology like a macular scar. If the child has a toxoplasma or a toxocara or a traumatic scar, this eye does not see, so he gets sensory strabismus or strabismus due to poor vision. And if we did not examine the fundus, we would perform occlusion therapy to treat amblyopia, and the patient is not amblyopic, he will never improve because we cannot remove the cause. So we have to know if there is a retinal pathology causing the strabismus or it's only strabismus with normal retina. Because the mode of treatment differs. For example, this child with the retinoblastoma needs treatment for the retinoblastoma, not for the strabismus. And if there's a scar, the patient will always have poor vision, so the prognosis of strabismus surgery is poor. The parents have to know that. that the strabismus can recur after surgery. So these are the steps of clinical evaluation of a case of strabismus: history taking, visual acuity measurement, sensory testing to test for binocular single vision, cover test, motility testing, measurement of the angle of ocular deviation, cycloplegic refraction, and fundus examination.